Ôi ơi ơi. À rồi, ok. Coke. Ma- Masuhala Coke. Pothola का पाम. अरे आ जाता धीरे घंटा है.
Sir, good evening. Namaskar, sir.
Good evening, TD. Good evening. Good evening, Ashish.
Charlie.
Himanshi, Dr. Jayanth को co-host कर दो, please. He is the first speaker.
Sir, you are not audible.
No.
Now you are.
Hello. Hello. Yes. Sure, sir. That will be fine, sir. Thank you.
Right, now whatever we do here.
Good evening, everyone. It's 7 o'clock, so we will start. And good afternoon and good morning to delegates who have joined from other parts of the world. I'm sure there are some new attendees today who were not there yesterday, so I'll just give a brief introduction. The Mahatma Gandhi University of Medical Sciences and Technology is a private medical university, the first such university in the state of Rajasthan. We have 7 affiliated colleges, including medical, dental, nursing, and other paramedical sciences. The Mahatma Gandhi Medical College Hospital is a 1,500-bed tertiary level referral hospital. The Department of Surgical Gastroenterology is a part of Center for Digestive Sciences, which includes medical and surgical gastroenterology, hepatology, and HPB surgery. And most probably, we are a unique institution in the country which has all these 4 separate independent departments. The Department of Surgical Gastroenterology was formally established by my colleague, Dr. Ajay Sharma, who joined as head of the Department of Surgical Gastroenterology. And we started the MCH Fellowship Training Program, 3-year post-general surgery training program in surgical gastroenterology. When my senior colleague, retired Major General R.P. Chaube, joined the department before I came in. And the liver transplant program at our institute is headed by Dr. Namish Mehta, who's the chief transplant surgeon at Gangaram Hospital. He's ably assisted in liver transplants by my young faculty colleagues, Dr. Anand Nagar, Dr. Shaswat Sareen, and Dr. Vinay Mahala. All the patients who come to us with chronic liver disease, they are looked after by the hepatology team, which is headed by Dr. Saraswat, who has had a long stint at SCPGI Lucknow, where I also worked for more than 3 decades, and Dr. Karan, his young faculty colleague. We have a separate independent department of organ transplant anesthesia, and all our liver transplants are looked after intraoperatively by Dr. Vipin Goyal, Dr. Gaurav Goyal, and Dr. Ganesh Nimje. And the post-operative care of these patients is provided by my colleague, Dr. Anand Kumar Jain. So Jaipur Surgical Tutorial actually is an online education portal which we started 2 years ago. It's being looked after and coordinated by my young faculty colleague, Dr. Anand Nagar. So in the chat, I have put his contact number. Those of you who want to join JST, please WhatsApp your name, institution, city, and country to him. We conduct a session every Saturday 9 to 10, and mainly related to GI and HPB surgery. And this masterclass is being presented by my former fellows who are now senior consultants in their own right at various institutions and hospitals in country, and who are actively involved in liver transplant. So it's their love and affection for me that they not only agreed to contribute, but also agreed that I, who have no hands-on experience with liver transplant, be the moderator. So thank you all very much. And I'm also, I have to express my thanks to Dr. Sonal Asthana, the current president of LTSI, who joined us yesterday to formally inaugurate this masterclass, and also agreed to send the information about the masterclass to the LTSI members. So with that introduction and background, I would hand over to Dr. Giriraj Bora. Giriraj, have you joined? Yeah, Dr. Giriraj has joined. Himanshi, please make Dr. G. Bora also as one of the co-hosts. He's going to chair.
Am I audible, sir? Good evening.
Yes, good evening. Over to you, Giriraj. Please take over. And let me introduce the speaker. Dr. Jayanth Reddy is the transplant and HPB surgeon at Apollo in Bengaluru. And Dr. Ashish Bansal is a member of faculty at the King George's Medical College in Lucknow, where they have started a transplant program recently. So Dr. Giriraj will be chairing, and Ashish would be the lead questionnaire. So he will start questioning Dr. Jayanth first. Giriraj, please start.
Hi, good evening, and thanks, sir, for your introduction and inviting me for this wonderful initiative. And it's, I mean, for last 2 years, I've heard that, I mean, these online classes have gained a lot of popularity among the various MPH and DNB students. So I guess, I mean, we are going to talk about donor hepatectomy, and the Dr. Jayanth Reddy will be, I mean, he'll be starting the talk on donor surgery and the various technical aspects of living donor liver transplantation from donor point of view. So, Dr. Jayanth, I mean, if you can share your slides and we can start the presentation.
Yes, sir. Just a second, trying to organize it. Good evening to everyone. Am I audible?
Yes, yes.
Yes, please. Please
Thank
carry
you
on.
for the kind introduction, and a big thank you to Professor V.K. Kapoor and the entire faculty at Mahatma Gandhi Hospital, Jaipur, for organizing this and having all of us over. Hope to share some knowledge that I've gathered over the years, which started off at SGPGI. I'll start off this presentation. I'll try and keep it brief and simple. So LDLT is a directed organ donation. There is an element of double equipoise, which is a clear judgment to balance the donor risk on one side with the recipient benefit on the other. As much as we may try, it may never be possible to justify a surgery which violates the core principle of medicine, that is primum non nocere, do no harm, because you're subjecting a perfectly healthy individual, not a patient, to a major surgical intervention so that he can be of help and improve the recipient that is invariably related to him. Despite taking all the precautions, donor complications are inevitable, and it remains the single biggest deterrent to performing live donor liver transplant. Keeping the donor risk to a bare minimum by an extensive donor evaluation and following surgical protocols stringently is of paramount importance. This includes standard operating procedures, which should be followed irrespective of which member of the operating team is on the donor side, regularly following checklists and having a disaster plan in place just in case there is a severe complication to the donor. Ongoing success of the live donor liver transplant entirely depends on donor safety, and donor safety, like I said, is paramount. Despite this, there have been reports of donor death, most of them unpublished, but there are centers which are brave enough and gone ahead and published. The first one is from India. It was published in 2010. In this case, the donor died because of acute severe pancreatitis. And then there was another personal viewpoint that was published in the AJP in 2010. This was from the United States. And this invariably attracts a lot of media attention, sometimes rightly so. It's extensively covered, and this is not good for the hospital, the program in general, and the overall development of live donor throughout the world. There have been extensive studies about the long-term outcomes of live liver donation. This is an analysis of a national database from South Korea, where the donor mortality across about 10,000 live liver donors was about 2.2%. And 2 of these deaths were within 60 days of live liver donation, so directly related to surgery. And when they compared the individuals who had donated their liver to the general population, there was an increased risk of death, mainly from suicide, cancer, and also the other unclassified reasons. And across the board, the liver donors were at higher risk than the controls. So long-term follow-up is very important. It is not just, they donate, you follow them up in the OPD for the first 3 to 6 months, and then you don't see them again. I think it's very important that you see them year on year, and including a psychosocial support is of paramount importance. And this is especially important when there is an adverse outcome to the recipient. Donor safety checklists, again, cannot stress more. Those who are accepted to donate have cleared the checklists, need to have a weekly review of their imaging until the day of surgery. There should be 2, preferably 3 independent reviews by the surgical team, and this minimizes the risk of missing any subtle anomalies and ongoing quality assurance and improvement of the surgical outcomes as a whole. All the blood workup should be repeated to ensure that these results are less than a month old when the donor is admitted for the surgery. Despite this, there are reports of aborted donor hepatectomy. Despite the extensive evaluation, we heard a wonderful talk yesterday. And despite this, this was a publication coming from Turkey, where about 77 donor candidates were aborted due to predominantly donor causes, and the main reason was quality of the liver parenchyma. I think in this day and age, this is sort of unacceptable. I think there are enough and more modalities available at our disposal to evaluate donors thoroughly so that this can be avoided at all costs. Surgical planning. This is a short video. I've taken this liberty to borrow. I've tried to get videos. I didn't have one of my own. This is from the Toronto Surgical Atlas. I'll quickly go through it. This is a live liver donor who's a 48-year-old lady, and the plan is for a donor right hepatectomy, excluding the middle hepatic vein. That is the middle hepatic vein stays with the donor, and the graft will consist of the right hepatic vein with segment 5 and 8 veins. So you can see the right hepatic vein here. This is the middle hepatic vein, and this is a large segment 8 vein joining this. And this is the main portal vein. There's a standard anatomy in this, and there is a right inferior hepatic vein in this case. The plane of transection in a live liver donor extends from the gallbladder fossa inferiorly to the groove between the right and the middle hepatic vein superiorly. This particular donor had a standard portal vein, a standard arterial anatomy, but had 2 bile ducts. So your type 3A, type 3B biliary anatomy, where the right posterior sectoral duct was joining the left hepatic duct. So the plane of transection after dividing will give you 2 bile ducts. In the end, a single portal vein, right hepatic vein, and the cut surface, we will get 1 segment 8 hepatic vein and 1 segment 5 and an inferior hepatic vein for bench reconstruction. It is important to pay attention to every single point when performing this surgery, starting off with patient positioning on the table. It is important to avoid neuropraxia injuries because there are retractors in place for the costal margin. Standard approach is where the arms are tucked in by the side of the body. There should be good padding between the arms and the retractor side posts. Large donors might need a side extension, and all pressure points should be padded. There should be devices in place to decrease the incidence of deep venous thrombosis in the post-operative period. A patient warmer should be there. The arterial lines should be compressed, and you should try your utmost level best to keep the anesthesia colleagues happy. Coming to the operative steps, the standard incision, I'm talking about open right standard donor hepatectomy. The reverse L incision is the standard that is used. Midline can be used, we've used it, but it is a challenge when there is a large liver graft, there are multiple right inferior hepatic veins or multiple portal veins where there is not enough space and all these vascular clamps are clashing with each other. Once you do the laparotomy, it is important to visualize and palpate the entire liver to ensure good quality. Then proceeding with mobilizing the right hemiliver by incising the right triangular and coronary ligaments. It is important when doing this to avoid unnoticed thermal damage to the diaphragm because we've had a personal instance where the donor came back to us about 3 months later with a large diaphragmatic hernia on the right side. And this was a publication. So it is important to minimize the use of the cautery, keep the cautery settings to a low, use forced coagulation setting instead of using a spray mode, and preferably use a monopolar forceps rather than a pencil cautery. Once the right hemiliver, as a part of the right hemiliver mobilization, you ligate and divide the caudate and short hepatic veins. You secure the divided ends with suture. You divide the hepatocaval ligament between vascular clamps, and any inferior right hepatic veins which are more than 5 millimeters should be preserved for a bench reconstruction. Suprahepatic vena cava is dissected, and the groove between the right and the middle hepatic vein is developed. an umbilical tape is passed in the groove between the right hepatic vein and the middle hepatic vein, and for an hanging maneuver.
theory କହୁଛନ୍ତି ବୁଝିଲୁ ଚିତ୍ରଟା କରି ଓଟିରେ ଦେଖେଇବା କିଛି ନାହିଁ ପୁରା theory.
So this is a video doing the right hemilever mobilization, dividing the right triangular ligaments. So it is important that you minimize thermal injury here. You stay in the loose areolar tissue between the diaphragm and the liver. Not to enter the liver capsule and all the short.
Not pani drink. This is just to
ligatures, and these should be again secured with proline sutures. And so this is an inferior right hepatic vein that is dissected. So this is looped. This is not divided at this stage.
No. This is all holes. Pani ante kindi kilpodu. See pani.
This is the hepatocaval
Pani drink.
Ligament, and this is some when it is large, it is better to divide it between clamps and overrun the divided ends with a proline suture. So once this is mobilized, there is a lot of space that we are able to gain access to. And once this is done, we are able to develop the plane between the right and the middle hepatic vein. So that is the inferior vena cava, accessory segment 6-7 branch below, and the right hepatic vein superiorly. And so here you pass a right angle and take the umbilical tape and pass it beneath the segment 6 and 7 right hepatic vein for completion of the hanging maneuver. Next would be the hilar dissection. This is the most important step, the initial step of a donor right hepatectomy. So retrograde cholecystectomy is performed. Calyx triangle dissection. It's good to leave a small cuff of the gallbladder at the lower end to facilitate cannulation of the cystic duct and for an intraoperative cholangiogram. The bile duct is retracted medially, and you need to be careful when doing this to avoid directly holding the bile duct. It's better to use a vein retractor when doing this. Once this is done, you dissect and loop the right hepatic artery proximal to the cystic artery branch, and avoid undue handling of the right hepatic artery during hilar dissection because it can go into spasm, and in worst case scenarios, it can even cause an arterial dissection. You divide the loose lymphatic and loose areolar tissue along the right border of the portal vein. And when doing this, it's important to make sure that if there is any replaced right hepatic artery or an early branching of the right hepatic artery, you are aware about this and you take the requisite safety measures to protect them. Before looping the right portal vein, we invariably will need to divide small caudate branches. And these should again be sutures. It is important to identify the takeoff of the left portal vein from the main portal vein while looping the right portal vein, and it is especially important when before retrieving the graft, when you place a vascular clamp on the right portal vein, that you're able to see the initial takeoff of the left portal vein from the main portal vein. It will be good to lower the hilar plate. This has helped us, towards the end when you're doing the biliary dissection, and also when using a marking clip before doing the intraoperative cholangiogram. Short video on the portal dissection. So starting off with dividing the gastrohepatic ligament and retrograde cholecystectomy. So the loose areolar tissue along the hepatocaval ligament is incised. So this patient had already had a cholecystectomy. So the ligament cystic duct is probed and then cannulated with 5 French infant feeding tube for intraoperative cholangiogram. It is good to retain a cuff of the gallbladder because we need to do this cholangiogram about 3 times throughout the course of surgery. And sometimes, when it is just in the cystic duct, because of the valves of Heaster, it is difficult to cannulate it. There you can see the right hepatic artery that is dissected and you can see how the surgeon is holding the loose areolar tissue on top of the bile duct and not holding the bile duct directly. So this is a marking clip. Once the hilar plate is lowered, this is an initial clip. So we can see the clip here. This is the clip and an intraoperative cholangiogram, and this is the plane of transection, which will be perpendicular to both the right anterior sectoral duct as well as the right posterior sectoral duct. The portal vein is now being dissected. So this is the small caudate branches, otherwise called the annoying veins, which need to be ligated between suture ligatures and then reinforced with proline sutures. So the portal vein is looped, and when doing this, it is good to have a small peak to make sure that the left portal vein, you're not looping the left portal vein accidentally. So intraoperative cholangiogram, it is selectively used in certain centers. There are centers like Rela Institute, which almost never use an intraoperative cholangiogram. They primarily rely on the biliary anatomy based on the MRCP that is done during workup. But we in our unit regularly use the intraoperative cholangiogram. So cystic duct is cannulated with a 5 French infant feeding tube. It is important to get the table position and the angle right. You place a large clip at the planned RHT transaction site, and you occlude the distal end of CBD. This is very, very important. We've had a couple of near misses with our donors, and in both these cases, it was because of pancreatitis. And the reason for pancreatitis was during the cholangiogram, because of a low insertion of the cystic duct on the CBD, there was opacification of the pancreatic duct by the contrast, and this led to the donors developing pancreatitis in the post-operative period. We are all aware about this. This is the Huang's classification. So type 1 is the standard biliary anatomy, type 2 stratification, type 3A is where the right anterior joins the left, right, and type 3B is the right posterior, 4A is when the right anterior is joining the common hepatic duct, and type 4B is where the right posterior sectoral duct joins the cystic duct or the common hepatic duct directly lower down. So these are pictures of some cholangiograms. So you can see here in the first one, the right posterior sectoral duct is joining the left hepatic duct, and similarly here in the second picture. And the third picture, you can see multiple ducts, which are all sort of coalescing together, trifurcation in the left lower column. And then here you can see the type 4B, where the posterior sectoral duct is joining the common hepatic duct lower on. The next step would be marking the transection plane. So you temporarily clamp the right hepatic artery and the right portal vein, identify the demarcation line, and score the liver surface with cautery. This groove, like we already discussed, runs from the right middle hepatic vein groove to the middle of the gallbladder fossa initially. At the lower end, it is important that you deviate the transection plane slightly into the base of segment 4 to ensure that when you're doing the biliary division, that there is an adequate liver parenchyma all around, and there is plate tissue around the right hepatic duct, so that you're not compromising on the vascularity of the right hepatic duct. Parenchymal transection, as a standard in most centers, is done by using the CUSA. It is important for the surgeon to be aware of the standard settings of the CUSA, which he is comfortable with. The portal structures during transection are usually white. The hepatic veins have bluish tinge. Small portal structures in hepatic veins during the transection are clipped or ligated. The segment 5 hepatic veins are usually encountered within a couple of centimeters of starting the parenchymal transection. If at doubt, it is about the position of the middle hepatic vein, it is important to follow the V5 and the V4 onto the middle hepatic vein without ligating any hepatic veins initially. And if unsure about the significance, you're not sure, you're on the CT, you feel that there was only one segment 5 hepatic vein, but when you're doing the parenchymal transection, you find that there is another segment 5 hepatic vein here, and you're not sure whether this is significant. You can assess by temporarily clamping these hepatic vein branches and at the same time occluding the right hepatic artery temporarily to see the area of congestion. And if it is not significant, these can be ligated and you proceed with your parenchymal transection.
Jayanth, we'll have to leave some time for the chair and audience also.
Sure,
So.
I'll speed it up. So parenchymal transection, it's important to stay on the right border of the middle hepatic vein. You need to bear the middle hepatic vein, and the hanging maneuver is useful when you are going around the segment 8 hepatic vein. The caudate division is the last part, and this is aided by the hanging maneuver. And as the transection approaches, you move to the left towards the segment 4, and then you complete the parenchymal transection. I'll rapidly run through this video. So this is scoring the hepatic parenchyma, from superiorly to inferiorly, and lower down you deviate slightly to the base of segment 4. The parenchymal transection is done by using the CUSA, and it is important to stay right on the middle hepatic vein and not deviate to the left or right, so that you are on the right plane. You can take stay sutures. So this is a large segment 8 hepatic vein, and the hanging maneuver is very useful. So here, once you complete the parenchymal transection above the segment 8 hepatic vein, you loop the umbilical tape lower down, and you can complete the rest of the transection. Before proceeding with the rest of the steps, it's important that only the biliary hyla plate is left. The bile duct division, you repeat an intraoperative cholangiogram. Again, you make sure that you know where you're going to transect the right hepatic duct. And once you confirm that, you divide the bile ducts sharply, the hyla plate sharply. And hemostasis of the hyla plate blood vessels, it's important that you do it right there and then not leave it for later. The duct lumen should be probed to make sure that you are in the right plane. Nothing should be assumed. The caudate duct should be closed, and the stump of the right hepatic duct should be closed with PDS sutures. And finally, you repeat a cholangiogram again to confirm. Type 3A and type 3B are a challenge. So sometimes you might have to repeat another cholangiogram after closing the first stump. So this is a biliary bile duct is being divided. So the first duct is divided, and then once that is done, you use a probe and make sure that you're not missing any duct. This is a small caudate duct that is there. Moving on, once this is done, you coordinate with the recipient surgical team. Never be in a hurry. Make sure that they have not run into any problems on the recipient side, so that you can reduce the cold ischemic time. As a first step, you ligate the right hepatic artery proximal to the origin of the cystic artery. Take care that you're not injuring the segment 4 artery in this process. And when applying the portal vein clamp, to ensure that you are visualizing the proximal portion of the left portal vein. In a type B or C portal vein, you need to clamp the anterior and the posterior portal vein separately. It will be good to take a marking suture to orient the posterior portal vein. So the outflow is then clamped, the RHV and the IRHV. It is good to apply the clamp on the vena cava so that you can take a small cuff, but not too much when you're clamping the right hepatic vein, because you don't want to compromise on the lumen of the inferior vena cava. Then subsequently, you divide the right portal vein, followed by the outflow. The graft is placed in a bowl, dipped in night flush, and then flushed with organ preservative solution. Then subsequently,
And I think we can leave the bench and you can continue.
Thank you. So, like I said, all portions of this is very, very important. Nothing can be taken for granted. This is by far, I think, the one of the most complex surgeries that we perform. And you can't perform it like a routine donor hepatectomy. Donor safety is of the primary importance in this surgery. So it is important that you are never carefree, never take anything for granted, and follow each step meticulously, like how you have set protocols in place. Thank you.
Giriraj?
Sir, Dr. Ashish, if he wants to ask some question,
Yes.
Yeah. Yes, sir. Sir, thank you. First of all, I thank Dr. Kapoor, sir, for giving me this opportunity. And so thank you for Jayanth, sir, for such an informative and such a beautifully animated videos and nice presentation, sir. Sir, I just wanted to know briefly about the role of ICG in donor hepatectomy in current day and age.
So ICG in the open donor hepatectomy, it is a challenge to use ICG. We have tried to use it in a couple of cases. but we hadn't had very good results. We still rely by the intraoperative cholangiogram, but in a minimally invasive hepatectomy, be it whether laparoscopic or robotic, I think ICG is of paramount importance because the intraoperative cholangiogram is not feasible in these situations, and the surgeon is primarily relying on the indocyanine green injection and delineation of the bile ducts for bile duct division safely. But we personally haven't had a good experience of using it in open donor.
Yes. Sir, one more question, sir. Thank you, sir. Sir, as we didn't discuss benching because of the lack of the time, whatever photos you have shown, you have used PTFE graft for the reconstruction of the MHV, sir. Correct. What is the take, sir, for the explant portal vein to be used as a MHV reconstruction?
Yeah, so initially we were using the explant portal vein and cadaver portal veins, but harvesting it has multiple holes, and it takes a lot of time. It takes more time than using a PTFE. And we did switch to PTFE. We were apprehensive, but these PTFEs that we are using are heparin coated. They are very pliable, and we use a single outflow. So we anastomose the segment 5 end to end with the PTFE. Then any other segment 5, the segment 8 end to side, and the end of the PTFE is joined to the right hepatic vein, and there is a single outflow. Once we started doing this, we found that our outflow issues are much lesser, and also the incidence of thrombosis of the neohepatic vein has come down. So we, in our unit, prefer to use the PTFEs over cadaveric vein or.
Yes, sir. One more small question, sir. As you have mentioned, the Gore-Tex suture. Many of us, as a surgical gastro colleague, we don't know about the importance of using Gore-Tex suture, sir. Yes. What is your take of using Gore-Tex over Prolene, sir?
So when we were using, so initially in this slide, you can see we are using Prolene sutures, but we found that the suture site holes usually bleed after reperfusion. With Gore-Tex, that is almost, we never see it, and it is very pliable, and it easily goes through, and the suture site bleeding during reperfusion is significantly lesser. The cost is a little bit of a constraint, but it definitely comes with its benefits.
Jayanth, if you could quickly take 2 or 3 questions in the chat.
Sure.
Very brief.
Jayanth, can I ask you a small question?
Giriraj, please.
So, you said, 2% of your donors had, some aberrant anatomy, and you abandoned the donor hepatectomy. So can you just, can you just tell us what kind of anatomy is a contraindication for, not going ahead?
Sir, I think in this day and era in India, unless until we encounter sort of 4 or more bile ducts inadvertently during a cholangiogram, I don't think that is a contraindication. That was a study that was published in 2010, and I just highlighted it just to say that the intraoperative cholangiogram still has a role in this present day and era. But I don't think we would negate proceeding with the donor hepatectomy just because of what the intraoperative cholangiogram shows.
Exactly, because even if there are 3 ducts,
yes.
So sometime, we have encountered that the donor has 3 ducts. 4 I have never seen practically. Yes. So 3 ducts, we have. Yes. Even if, 1 duct gets stricture in the long term, you can always embolize the portal vein of that particular, segment, and you can, then that subsequent atrophy doesn't cause any long-term, biliary complication in the recipient as per. And the second question, you said that in the RELA Institute, they are not doing intraop cholangiogram. Yeah. In fact, in NCR, it is slightly different practice. There are centers who are not doing MRCP and they are just doing intraop cholangiogram. So it's a different kind of a practice, here. So here people, because they know, they can handle, any kind of biliary anatomy. So they are not doing pre-op MR. In fact, intraop cholangiogram, they are performing, and in most of the donors, biliary anatomy as such has not been an issue anymore, to abandon the donor hepatectomy.
Absolutely. So from my understanding, the Prof. Rela's Institute changed because of this unfortunate incident where they had this pancreatitis develop in the donor, and they felt that they're able to get an equally good imaging on the MRC.
Right.
So, Jayanth, we have 4 or 5 minutes. Quickly, if you can take the questions in the chat.
Sure. Absolute contraindications to anatomical variations, I think, would be where there is a single portal vein which is supplying the liver in entirety. The other would be sort of a portal vein where the right anterior branch is coming off well high up from the left portal vein. That is something I would be apprehensive of, at least initially during the my career. Otherwise, the two arteries, multiple bile ducts, like Dr. Giriraj Bora said, is not a contraindication. Donor in reference to the recipient hepatectomy concerns. So we would always like to start the donor first. There are a few instances where we would start the recipient first. One would be a retransplant, and second would be where there is a HCC beyond Milan. And especially in instances where we have treated portal vein tumor thrombus and we have downsized, we would like to start the recipient first, make sure that there is no extrahepatic disease we are missing before starting the donor. Intra-op donor liver biopsy, I don't think has any role. If at all anything should be done, should be during the evaluation period. Diameter of the PTFE graft, we prefer to use an 8 mm or a 10 mm. Earlier, we using the regular ones, non-heparin coated, but nowadays the heparin coated is much more pliable, and it is, we found it at least to be more patent. Slit-like opening of V8, when do you do a venoplasty, V8 and RHV? So we've started using a single outflow by what Dr. Pamecha and team have described, and we have found that the implant time is shorter, and our at least experience with problems with outflow and thrombosis of the new MHV has significantly come down with this. Caudate lobe division, yes, I would like to perform a caudate lobe division before the hilar division. You would prefer not to loop the hilar plate in entirety. Just make sure that you've completely done the parenchymal transection, and once you're sure with that, then you confirm where you're going to divide the bile duct and go ahead. No dissecting on the bile duct, completely avoided. MHV in the right graft, we would include it only if the donor is young. The FLR in the donor is close, easily more than closer to 40%, because you need to take into consideration the congestion volumes also. And very rarely have we found, except for a partial MHV where there are multiple segment 5 hepatic veins, you could include a partial MHV, but a total MHV we would try and avoid as much as possible, again, because donor safety is of paramount importance. Patient in the post LDLT setting, operative, non-operative, PVT.
I think we will leave that for the complications part. So sure. I think we have to stop. We are already at 7:40. So
apologies for the delay.
Yeah. Thank you, Jayanth. Thank you, Giriraj. Thank you, Ashish.
Thank you so much.
We will move on to the next topic. So next is Dr. TD Yadav, who is the Professor of Surgical Gastroenterology at PGI Chandigarh, also the Secretary of the IHPBA. He's going to talk about recipient hepatectomy, and I would request Dr. Jayanth to stay on to chair Dr. Yadav's talk. Jayanth, please start. Unmute yourself.
Good evening, sir. Fond memories of seeing you in SGPGI. It has been a long time. Looking forward to this talk eagerly, and it's a privilege to share this session.
GD, please go ahead.
Good evening, and good evening, Dr. Jayanth. Good evening, sir, and namaskar to all of you. So, is my screen visible? No, I don't think so. I have shared my screen. Dr. Jayanth, have you stopped? Yes, sir.
Jayanth, you stop sharing, and then maybe TD can share again.
I have stopped sharing.
Yeah, okay.
Just, so share screen. Participants can now see your white.
Blank, although it says that we are.
हवा चल रही है यार बाहर.
Hello, Myra, कहाँ हो तुम?
It is sharing my screen, but why
It is
not
sharing, but
my...
we are seeing only blank white screen. Himanshi, anybody can give any tips? What should we do?
I think the whiteboard has been activated there. It's showing a whiteboard.
Yes, yes, yes.
Yeah, so that has to be closed. This has to be closed. Open the PowerPoint slide and then share.
PowerPoint slide.
Sir, close and reopen.
I'm sharing up again. No, PowerPoint slide is open.
Yes.
So is it visible, sir, now?
Somebody is suggesting that you log out and log in again. Dr. Yasir Khan from Pakistan, he is suggesting that you log out and then log in again.
Participants can now see the whiteboard is seen, sir.
His whiteboard.
So I should log out and log in again.
Yes, yes, that's what Dr. Yasir is suggesting.
Sir, so leave them.
In the meantime, let me tell those who were there yesterday also and who are there today also, I forgot to mention that yesterday Dr. Balachandran, in spite of the fact that he is abroad, he is in Myanmar, he agreed to join and deliver his talk. So I forgot to mention that, and I must say a special thanks to him for that. Jayanth, maybe you can take the remaining questions while TD is logging in. Why don't you? Yeah. So this one, any impact on RHV?
Impact on RHV to thrombosis of the personal. No, we've not had any problems with RHV because of new MHV thrombosis. Even even there is an inferior hepatic vein. We try to do a single outflow reconstruction where we put the inferior hepatic vein also to the lower end of the.
Sir, host, it is coming that host has disabled participant screen sharing.
Himanshi, please. But you
it
are
is showing that.
So you should
so
be.
Why host disabled participant screen sharing. This is coming on my screen.
Let me talk to Himanshi. Himanshi is the key person at Avinash Tank's team. She's been helping us in all the online activities of JST. Yeah, Jayanth, please go on.
Dominant MHV a contraindication for right lobe graft? No, because even in dominant MHV, so the segment A5 and A8 hepatic veins will need to be obviously very well reconstructed. The right hepatic vein will be thin. So dominant MHV is not a contraindication, but we'll need to sort of also see what the recipient characteristics are before accepting a donor like this. What would be the FLR? And I would be apprehensive of using such a donor, especially in somebody with a high MELD score and who's on the heavier side and who will require definitely a larger functional liver volume.
Did you try sharing now? She has enabled sharing the screen. I must thank Dr. Yasir Khan, who has been there throughout yesterday and today also. He is from Pakistan Kidney and Liver Institute. Dr. Yasir, maybe you can come in for a minute on the video for all of us.
Sir, I have started sharing.
नहीं वो whiteboard आ रहा आपका कुछ problem है. I think we will probably proceed with the next talk, and if you can seek somebody's help. Thank you, Dr. Yasir, for joining and asking questions and commenting. Thank you very much. Thank you. So
thank you.
Yeah, but I don't think Amit is still logged in.
Why still? Why, sir? Why whiteboard should come? I don't understand. Never it comes like whiteboard. So there is some problem.
आपने अपना PowerPoint presentation खोला हुआ है?
हाँ जी सर.
तो एक बार stop share करो, फिर share करो, और फिर उसको select करो.
My PowerPoint presentation opened है sir.
नहीं, एक बार stop share कर दो.
मैं करता हूँ.
Big there. This is low key. There and just might use it.
Oh, hi, Mams.
Now I'm sharing again.
No, there is some software issue, which is again whiteboard.
He can try restarting the computer, completely logging off, stopping the computer and putting it back on again.
It never happened.
Sir, Dr. Kapoor, sir, I think there's some problem in the settings from your side only, sir, because when we are I just tried to check the share screen. It is not giving the usual share your whole screen, or it only shows whiteboard and Google Chrome something. So sir is only having whiteboard as an option. Because of that, there's no the regular option of share your PPT or share your complete screen is not coming.
But मेरे में तो आ रहा है. For me, it is coming. Let me ask you.
Are you using Mac, sir? Yadav sir, आप Mac
Mac use कर रहा हूँ. Yes.
ये Mac का problem है क्या? Check. Let me just.
The meanwhile, can we move on to the next talk?
I think actually Amit Rastogi has not logged in. So maybe since you and Phani are there, we can go on to complications. It doesn't matter if the order gets changed, because otherwise we will be spending time.
Phani is ready. Is he?
Yeah, I'm ready. See, I think with this problem, I've sent it to the madam there, the presentation.
I will. Or TD, mail it to me. Mail it to me. I will.
I'll mail it to you.
So I have a.
Yeah, you can.
Sir, I have a video. So I'm forwarding the video and sending the mail.
But you try shutting down your computer and log in again. In the meantime, we'll go ahead with the complications talk. So we will slightly change the order. I will now request Dr. RavulaPhani Krishna, who is at Pace Hospital in Hyderabad, who will be presenting his talk on complications, and Dr. PaariVijayaragavan, who is at the Powai Medical Center Hospital in Coimbatore, he will be chairing. Over to you, Pari.
Thank you, sir. So I think no better platform to start Phani's talk. Complications. This is exactly what happens. It happens at the most unfortunate and most unexpected times, and we really have to be ready for it.
Sir, I mailed you my presentation.
No, you share your screen.
Let me just try that.
Oh, you are not able to?
I'm not able to.
Okay, let me just.
Maybe it's a Mac or this thing kind of problem.
You are also using a Mac?
Mine is a MacBook, sir. So, but I've sent it to you, and I've sent it to Avinash, the lady who called the secretary.
Himanshi, yes.
Yeah.
Himanshi, have you received Dr. Phani Krishna's presentation? Can you upload it? I haven't received it as yet. Well, now I have. Yes, I'll do it. I'll do it.
Yeah.
Okay.
So at the outset, first, let me thank the Jaipur Surgical Society and especially Dr. Kapoor for this opportunity. It's really an honor and pleasure for me to sort of share this platform with my beloved friends from Sanjay Gandhi. The topic given to me is complications of LDLT. It's a very vast topic, obviously, because next slide, please. Next slide, please. Can I do that? Yeah, it's a very vast topic because LDLT being an extremely complex surgery, so you don't have just the traditional complications which can occur in any major surgery, such as bleeding, cardiorespiratory problems, renal and pancreatic disturbances. You have a lot of LDLT specific, liver transplant specific and LDLT specific problems which can occur post transplant. So in these 15 minutes, I'll just try to give you a very brief overview, and also I'll be touching upon mainly the complications in the early post-operative period, not the late complications. Early means we generally refer to the first 3 months after surgery. Next slide. So the hepatic artery thrombosis is one of the most dreaded and severe complications after LDLT, and it's the leading cause of morbidity and mortality. The reported incidence is between 2.5 to 9% worldwide literature, but generally an acceptable rate would be somewhere between 3 to 5% is the accepted rate. There's a lot of data and a lot of publications about what are the risk factors for hepatic artery thrombosis following liver transplant. But these are some of the most common in the various publications. See, looking at the cadaveric donors, elderly donors and a prolonged cold ischemia time are important factors. Smokers, across ABO incompatibility transfers, you have higher incidence of arterial and biliary problems. Surgical factors, especially when there's a large size discrepancy between the donor and the recipient vessels, when there's intimal dissection and multiple revisions at surgery have been made. And like I said, pediatric transplant, because of the smaller caliber of the vessels, the incidence of hepatic artery thrombosis is more, and a lot of blood product usage, severe hypotension post-surgery. And sometimes, like when you have severe ischemia reperfusion injury or severe rejection, that means basically there's so much of graft edema that there's so much of inflow resistance, so that can precipitate hepatic artery thrombosis. So likewise, on the contrary, there's no level 1 data, but there are studies which show that basically microvascular techniques, non-comparative studies, in centers using doing the anastomosis through the operative microscope, you might have lesser incidence of hepatic artery thrombosis. And as the center's volume goes up, definitely the rates have decreased. So the hepatic artery thrombosis, based on the duration, is classified into early as well and late. In the early also, let's break it into 2 groups, very early within the first 2 weeks and after 2 weeks. Basically, how this presentation differs is as time progresses post-transplant, some degree of collaterals develop around especially around the bile duct. And so the severity is a bit muted and it's indolent. So in the first 2 weeks, let's see, first 2 weeks, basically, the patient is most of the time in hospital and he's getting a Doppler done every day. So many times it's picked up during the when the patient has a bit of transaminitis, immediately as a part of the protocol or as a part of the daily Doppler, we get the Doppler done, and it picks up hepatic artery thrombosis on the Doppler. But if the presentation is so fulminant, if it's missed in the morning, by evening the patient will have a severe transaminitis, enzymes going into thousands, lactates shooting up to 8, 10, and fever, hypotension, ascites, and there's a rapid iteration. So within the first 2 weeks, hepatic artery thrombosis is very fulminant. I mean, compared to the normal liver in us, there is some degree of collaterals for the phrenic and the left gastric, left phrenic side, but in the transplanted graft, obviously there's no alternate route to arterial supply, so it's a very fulminant presentation. But the same thing after 2 weeks. So after 2 weeks, it's a bit less severe. That means if the hepatic artery thrombosis occurs, the LFTs will not so drastically get altered. There'll be mild derangements, mild cholestasis. The lactates also don't shoot up so drastically. It's a bit more indolent course, but still as severe. So it's a bit more slow course, but still as deadly, because what happens is the bile ducts, the predominant blood supply of the bile ducts is arterial. So there's bile duct ischemia. It starts with anastomotic leaks, intrahepatic bile duct necrosis, multiple intrahepatic abscesses, which goes on to sepsis and graft failure. So unless an intervention is done immediately and we sort out the problem, the first 2 weeks, we sort out the problem, we go for a transplant, the first 2 weeks is almost near mortality. The another presentation is late presentation. So as I said, as time goes, move on from transplant, the collaterals develop. At late presentation, after 4 weeks, it's a relatively indolent course. So patient will have some degree of collaterals, the LFTs and the lactates. We may not get very sick, but over a period of time, biliary issues develop, like mostly non-anastomotic strictures, which is a good sign of arterial ischemia, not just at the anastomosis, but long segmental intrahepatic strictures. Then patients present with recurrent cholangitis and also chronic rejection. Basically, chronic rejection is because the patient is having recurrent septic issues. He's on very low immunosuppression in his post-operative period. And this leads to a chronic rejection. Next slide, please. So the diagnosis by Doppler, I mean, Doppler is obviously the basic screening test, but Doppler can sometimes be false negative. That is, for example, if the patient is on multiple inotropes, there's an arterial spasm, or if there's severe graft edema, the Doppler can be false negative. So the contrast enhanced ultrasound using nanobubbles, that's now available widely in India also. It is a better bedside screening tool than Doppler to screen for artery if you have a doubt. But once you have any such doubt, it's immediately, I mean, this is obviously a dire emergency. The patient is immediately taken for a CT angio, and the CT angio is very sensitive and specific for arterial thrombosis. So angiogram is not, unless you're planning an intervention of some sort of a stenting or a thrombolysis, you would not routinely do the angiogram. The CT angio suffices. So once you have a thrombosis, it requires an immediate reintervention. So within the first week, the reintervention has to be almost always surgical, because you can't do thrombolysis, a lot of raw areas and venous tubes, so the patient can have massive bleed after thrombolysis. So we go in to revascularize, either we redo the anastomosis. If the distal artery is very unhealthy and dissected, there's nothing much we can do. But if the proximal artery is very unhealthy and dissected, we can use an alternative, like a conduit can be used. If you have a cadaver, an iliac vessel, or a PTFE graft, conduit from the aorta can be used. After the first week, 10 days, endovascular revascularization is fairly successful. In series which have done this, about 60 to 70%, they've been able to maintain the patency. Basically, endovascular, you go in, you do a thrombolysis, do an angioplasty, and put in a stent most of the time. But in case in the early post-op or the late post-op, if you're too late to intervene, or we're not able to re-establish circulation, or the patient has got very sick because the liver is already infarcted, the only option is a retransplant. So this is a very serious complication. The mortality is up to 1/3. 1 out of 3 patients with the hepatic artery thrombosis dies. I think it's more in the Indian scenario, at least in our setup and elsewhere also, because most of the time in the West, whenever you have a hepatic artery thrombosis, you have a super urgent listing option. So immediately the patient will be in the nationwide database. He'll get the next liver that comes, and is very likely to get a liver in the next 48, 72 hours. In the living donor scenario, that's not much of an option. Super urgent listing is also very rarely succeeds. So mortality is higher in the Indian scenario. So basically in our setup, the prevention is the best way. The meticulous technique, choosing your, the vessels, the healthy vessels, make sure that there's no intimal dissection. If dissection, repair it, preferably a microvascular anastomosis. Though there's not much of evidence in the high risk anastomosis, we routinely use an alprostol infusion. Low molecular weight heparin, ecosprin are also routinely used to prevent thrombosis, and aggressive imaging is done. Next slide, please. Yeah, another complication, this is less common than hepatic artery thrombosis, definitely. Hepatic artery stenosis, I mean, the literature says high percentage, but we do see it much less common, and it generally doesn't occur in the first few days. It's usually after the first week. Basically, what happens is in your Dopplers, you can see here, the normal arterial upstroke, it's like a really sharp upstroke, very fast spike from the basal to the highest peak systolic velocity. This becomes flatter. So that's called Tardus Powers phenomenon. That is, the systolic acceleration time is prolonged and the resistance Ri is low. So this indicates, and across the proximal to the anastomosis in the hepatic artery, in the recipient hepatic artery, proximal to the anastomosis, there is high flow. So by these things, we identify that patient has a Tardus Powers. So immediately this has to be taken up in angiography. So if the hepatic artery stenosis is less than 50% and the patient is doing okay, you can just wait and watch. But if it's more than 50, moderate, more than 50%, severe, more than 75%, in these cases, it's always better to intervene and do an angioplasty. Generally, angioplasty, like I said, it is done after the first 10 days because thrombolysis is less dangerous. And then in the early part, if you put in a stent, there's always a risk of rupturing the anastomosis. Other rare complications are hepatic artery pseudoaneurysm. I mean, this is a very rare complication, but any high volume center would have definitely seen it a couple of times. So this is basically a combination of some problem with the artery with local sepsis. So that local sepsis could be a local bile leak, systemic sepsis, or many times fungemia. Then this can have a present like it can present like hemophilia if it's intrahepatic. It can present like GI bleed or intra-abdominal bleed. The treatment remains the same. Within the first week, it's exploration, and later on, it is stenting. Another unusual complication we've seen a couple of cases is basically in the post-op, your radiologist says that there's some degree of liver dysfunction. Your radiologist says the diastolic flow, this part of the curve is very flat. It's almost on the floor. So diastolic flow is very poor. Then when you do an angio, you see that there's no narrowing in your anastomosis, but because the splenic artery or sometimes the GDA, they're very large caliber. So they're doing there's a steal phenomenon. So in that case, you sort of go in and embolize them and it improves. Next slide, please. The next complication specific to the, sir, can we make it a full screen? Is it possible? The next complication, which is very specific to the living donor scenario, is
Himanshi, can you make it a slideshow?
Next, it's very specific to the LDLT is the neo-MHV thrombosis. I think obviously it's been discussed just now. So in the right lobe grafts, most of the time for donor safety, we don't take the MHV with the graft, and the segment 5 vein and the segment 8 vein are implanted into the either a native portal vein or a vein graft, cadaveric vein graft, or a PTFE graft. So this neo-MHV can thrombose, and this is a fairly common problem. It's in 3-month follow-up up to 1/3 of them, and in fact maybe in more of them, more patients, because if patient is doing well, we don't routinely do CT and all that. So this neo-MHV thrombosis can occur. So in the early this presentation of the neo-MHV thrombosis is highly variable. So it depends on, like, I think it was being discussed just now, how dominant is the middle hepatic vein versus the right hepatic vein. So if I have a dominant right hepatic vein with good collateralization, you'll have minimal symptoms, or you can have, some patients can have subtle derangement of LFTs, in which we evaluate and find this, or they can have a dramatic picture, like suddenly one day that bilirubin doubles and the enzymes double and you're thinking it's some rejection or septic hit or arterial thrombosis. So it can, so depending on how dominant the RHV versus MHV circulation is and how good the collateralization is, it can be a fairly large. So then it becomes a small for size graft, basically small for size because one is because the liver is congested and infarcted, and there is the effective volume of the liver comes down, and also there's a relative portal hyperperfusion. That is, the inflow to outflow balance is lost. Because of this, patient behaves like a small for size, graft dysfunction, increased ascites, not doing well, bili, cholestasis, enzyme derangements, and prone to sepsis. So this is, I think, an Indian publication, I think from Dr. Subhash Gupta's group. They showed in their short-term morbidity versus mortality, morbidity, this is morbidity, in the patients who had neo-HV thrombosis was 50% compared to 20% in the non-thrombosis group. So it's a very important and significant complication. While late neo-MHV thrombosis, especially if the MHV is not dominant, is fairly well tolerated. Neo-MHV thrombosis again by a Doppler, but Doppler can many times miss it because it has to be done by a radiologist who's really good at regularly doing living donor Dopplers, because the RHV and the portal vein artery are also fairly easy to find, but for this the radiologist needs to be experienced. And contrast enhanced ultrasound is there, but whenever you have any such doubt, any LFT derangement, any suspicion, as a protocol, we get a two-phase CT, and in that you pick it up. So LHV and RHV thrombosis in living donor transplant is very rare. This can be, unlike some really gross issues like the big twist in the graft occurs. If not, it's very rare. What is more common is stenosis. Basically, this sort of presents late after the first couple of weeks, a patient presenting with graft dysfunction and ascites. Madam, you've actually sort of enlarged the screen. Just make it a normal size. Some slide, part of the slide is gone. It's okay if you just keep it in the presentation mode. Yeah, that's fine. That's it. Thank you, madam. So basically, you see this. Normally the hepatic vein flow is triphasic. There are two negative waves, one positive wave, two negative waves, one positive wave. So the radiologist says that is monophasic waveform. It's not always worrisome. Just monophasic, you don't need to immediately panic. But if clinically the ascites, cholestasis, patient not settling with a monophasic foreground and a high gradient flow across the anastomosis is there on Doppler, then these patients, we need to do a CT angio, document the narrowing, and treatment remains, hepatic venous pressure gradient is measured, and a angioplasty with a hepatic vein stenting is done, following which the patients usually respond very well. Next slide, please. Portal vein thrombosis is the next vascular complication. It's a relatively, in the adult living donor scenario, portal vein thrombosis is a rare complication. It's more common in pediatric because most of the time in pediatric, you have the portal vein is attenuated and you need a more complex reconstruction, like putting a PDFE or a venous graft from the SMV splenic vein junction. And in patients with split liver transplantation, patients with a preoperative in adults with a patient with a pre-existing thrombus where you've done a thrombectomy, when there's complex reconstruction like 2 portal veins or a long segment graft being put, these are the patients where it occurs. When it does occur in the early postoperative, it's again a pretty serious complication. When the early portal vein thrombus occurs, there's massive ascites, severe abdominal pain related to bowel congestion, liver dysfunction, bowel edema, and portal hypertensive bleed. So the diagnosis is fairly simple. It's immediately diagnosed by Doppler and confirmed on CT scan. Like for artery, if it happens within the first week after transplant, the only option is re-exploration, redo the portal vein, and then put them on anticoagulation, therapeutic anticoagulation. While if it happens a week after surgery, a week, 10 days after surgery, you can try thrombolytic therapy and anticoagulation. But again, in both arterial or portal venous thrombosis, if it doesn't succeed, the option is only retransplantation. The same thing when the portal vein thrombosis occurs late. So this is mostly, when the patient is on OPD follow-up, it doesn't really affect the immediate outcomes much, only it leads to portal hypertension. Portal hypertension is treated medically and preferably tips to reduce the portal hypertensive complications. Next slide, please. So the biliary complications are the Achilles heel of liver transplantation. So the incidence of biliary complications in LDLT is high, as high as 10 to 30%. The late onset strictures needing intervention between 1 to 5 years are 20%. So probably 1 out of 5 of your LDLT patients is going to need have a biliary stricture and need an intervention. I feel, in fact, the percentage is probably bit more in our country. The reason why I say is in West, they have like this, they have the cadaveric option. So they accept type 1 and type 2 anatomy. But in the UK, at least in my time, type 3, which is a very challenging, especially when this gap between these two ducts is more, the right anterior, right posterior is more, or type 3B anatomy, these kind of anatomies, they would not accept because they have the living donor cadaveric option. Well, in India, we don't really have much of a choice. We accept all the biliary anatomies. So complications are obviously because of these variations more in the right lobe grafts. Left lobe grafts, there's not much of variation. They showed that the cutoff, this is large publications are there from Korea. The duct size less than 4 millimeters, the higher incidence of stricture. There's fairly good data to show that hepaticojejunostomy is superior to a duct-to-duct anastomosis in avoiding biliary strictures. But most of the time, because hepaticojejunostomy involves opening a rule limb and then another anastomosis plus a duct-to-duct, you always have an option of doing it's simpler to do it, and there's also the Yes, up, madam.
I think funny. I will interrupt. Maybe we can leave the rejection part and have some discussion on the technical complications.
So till what time do we go?
Do you have anything else other than rejection?
That's it, sir. Basically, the slides, maybe just the other complications, like these are the biliary. Maybe I can just complete the biliary and we just rest.
Yes.
We can list
I think we can stick on with only technical complications.
Yes. Go up, madam.
Yeah. No, you want to add anything other than rejection?
The biliary, let me complete that, sir. Technical
Yes,
complication, then we can wind up. Rest.
Okay. Yeah.
Madam, can you go up previous slide?
Go to the previous slide, please, Himanshi.
Yeah. So, the HJ is superior to duct, and then hepatic artery issues and ABO incompatibility. These patients also have biliary complications. So, the biliary complications are mainly leaks and strictures. Obviously, early post-op is more of leaks. The biloma presentation is not like in your regular post-operative patients, not always with pain and fever. They may have more subtle presentation, like just something with cholestasis and graft dysfunction. And so then we evaluate and find it on the CT or the MRCP. Some centers in the early bileaks, they re-explore and do a revision hepaticojejunostomy, but most of the time we are like less aggressive with these because you go in and revising also, it's all very friable. So the interventions is usually in terms of a ERCP or a PCD. Then likewise strictures, they occur late. Again, the problem with you can have LFT derangements, cholangitis abscess. But stricture holes, sometimes it's very difficult to diagnose because unlike the regular livers or in the normal liver, non-transplant liver or a cadaveric liver, you don't see much of intrahepatic biliary radical dilatation. Only there is no dilatation or minimal dilatation. There's loss of signal only at the anastomosis. Sometimes you have bile duct CAS. So it's very difficult to make the decision. So sometimes it's a combination of clinical acumen, do a biopsy, also rule out rejection, and then go in for the biliary intervention. So sometimes the decision making is difficult in LDLT. So when you have strictures, you have to differentiate between anastomotic and non-anastomotic strictures. Basically, anastomotic strictures are usually short segment, mostly related to technical factors, while non-anastomotic strictures are going to be hepatic artery related. They're going to be difficult to manage, and most of the time patient may need to be relisted. So the treatment is mainly by ERCP is the preferred route, but many of these patients, because especially the right lobe graft, there's a lot of difficulty with the angles and all that, or one particular segment you're trying to enter. So then you might have to do a rendezvous. And if you're not able to get across, option is surgical revision. Again, surgical revision in a cadaver is very easy, relatively easy, because it's just going to go above and open the left duct like a Hep-Quinard approach. While in living donor, it's very tough option. I think this completes the technical issues, sir.
So, Paari, maybe you can start the discussion.
Yeah, Funny, really fantastic presentation on the post-operative complications. A couple of things I wanted to add myself. After that, let's take the questions. You talked very well about the hepatic artery thrombosis, but you mentioned splenic artery thrombosis as a passing remark only. In my opinion, the hepatic artery, especially in the living donor setting, is is so small and it's so unforgiving. Either it runs or it doesn't run. If there is a technical issue, it just doesn't run beyond a few hours or beyond the theater itself. So what happens, in my own understanding, is if the hepatic artery thrombosis happens after a couple of days or a couple of 1 or 2 weeks, I guess the important factor is a portal hyperperfusion, because there is a suboptimal anastomosis there, and which is superimposed on a portal hyperperfusion, then probably the hepatic artery thrombosis happens. If it's a pure technical issue, I guess it happens on table or by the time within the first 24 hours. So what is portal hyperperfusion? Funny, would you like to explain in little bit detail for the sake of PGs, portal hyperperfusion and how the hepatic artery buffer?
So basically, I mean, the thing is, once you do the portal vein anastomosis, there's two things. One is that you only for half the liver, you're giving the full liver's portal inflow is coming up. So there many times it's been the accepted level of portal flow is sort of like 100 ml per gram per minute. That is the sort of flow, about double the portal flow of the normal liver is accepted. But when there is portal hyperperfusion, so that's like more than 2 times, or real severe is more than 4 times the flow, that leads to basically a shear injury and liver dysfunction, what we call a small for size, and also there's some degree of relative congestion of the liver, because there's a relative functional outflow obstruction, we call it, because the inflow is too much and outflow is not able to match.
This is how I saw him when I saw him first time.
First time.
I can hear a lot of other voices.
Yeah, others, can you kindly unmute? Sorry, mute yourself.
Yeah. So basically now, once we do the transplant and we assess the portal flow, there's the concept of splenic artery modulation has come in to like splenic artery ligation. I meant splenic artery ligation to sort of reduce the portal flow. But normally what we do is at the end of the surgery, especially if it's a borderline small size graft, or we are outflow or something, what we would do is measure the portal pressure. If the portal pressure is more than 15, or if the flow is more than twice the regular the normal flow, then we would do a portal modulation. So portal vein flow modulation by doing a splenic artery ligation. So this is good to prevent not just the portal hyperperfusion related injury, but also like relative liver congestion in the post-op, which may predispose you to arterial thrombosis as well. Fantastic. I hope that was your question, Ben.
Yeah. So hepatic artery buffer. So for the sake of the postgraduates there, so the portal flow and the hepatic artery flow are inversely related to each other. So the portal flow is more, the hepatic artery flow is going to be less, and vice versa. Not always vice versa, but when the portal flow is high, the hepatic artery flow will be reduced. So when there is a very high portal flow, the hepatic artery goes into sort of a spasm, and when there is already a suboptimal anastomosis there, it thromboses off. So that is one thing which I guess people have to understand.
Quickly, if you can take the questions in the chat.
Sure, sir.
We'll finish in another 3-4 minutes.
Yeah.
Why no hyperperfusion in donor ever?
So, yeah, there is hyperperfusion injury in the donor also. That's why when you have that is the mechanism of when you have a small remnant, they can have persistent high ascites. The bilirubin may take time, and occasionally you see liver failure. So the hyperperfusion injury occurs in donor also, but in the recipient, obviously the metabolic load on the liver is more, and there's other factors like ischemia, reperfusion injury, and all these, like Pari was saying, there's relative outflow obstruction because the inflow is more and outflow is not so much. So then congestion and all these problems can occur.
Right. So one more question from me, which you can answer for the sake of the younger audience. Why do we need to do Dopplers twice a day? So
basically, there's a golden window. I mean, in the hepatic artery thrombosis, once you have a hepatic artery thrombosis, like I said, unlike the normal liver, when the hepatic artery goes, there is some degree of collaterals from the phrenic and all those collaterals. So liver survives for some time. But in the transplanted liver, there is no other collateral. And as you know, 50% of the oxygen is from the liver, and the predominant biliary supply is from the liver. So there's a very small window before the patient LFT gets badly damaged or the liver starts infarcting, you should identify and sort of treat this problem. So to identify the patient in that window, especially the high risk anastomosis, we should frequently keep doing Dopplers, because once that golden window passes and there's an enzyme rise and the liver infarct starts, even if re-intervention may be useless.
Yeah. Can I put it this way? So you have to catch it before actually it shows up on the LFT. So that is the reason why we got to do the Dopplers very frequently. If it's already showing up on LFT, it means that it's little too late. Any other questions?
There are 2 or 3 more questions. Quickly, please, Funny.
It has the method of biliary reconstruction in relation to the stricture rate and regards to posteriorly intermediate with knot inside or knots outside continuous running suture. Basically, the method of biliary reconstruction, there is good data showing that the hepaticojejunostomy is the preferred anastomosis compared to the duct to duct, especially when you have the type 3A anatomy, which is at least in 1 out of 5 patients, we see the type 3A anatomy with the gap between the ducts is very far away. And many of the times the duct alone cannot reach both these ducts, and we end up doing a suboptimal bile duct anastomosis, and they're very small anastomosis. So there's literature showing that the hepaticojejunostomy is much better, but obviously there's a bit reluctance on everyone's part to go for that because it involves opening bowel during surgery, doing another anastomosis, and the post-op re-intervention also, the stricture, the intervention, the radiologist, obviously in the first couple of weeks, first 2-3 weeks after surgery, liver is very soft and you can't do a PTBD. So you're stuck then. So while if you do a duct to duct, you have still an ERCP is a chance. So basically what I meant was the HJ is preferred, especially when you have 2 ducts. I think there's data.
No, I guess funny. The question was whether you'll have the knots inside or outside.
No, method of biliary reconstruction in relation to stricture rate. Yeah. So the knots inside or outside, usually the posterior we do continuous because most of the time the suture used is in living donor is 6O PDS. And when you have PDS is a stiff knot, it stays in for 6 months. And you don't want to have, and we leave 5 to 6 throws on that. So it's going to be a bulky suture. It could be a nidus for a stone crystal formation on that and obstruction. So posterior we do always continuous. Some people try to put the posterior knots behind the bile duct. So, but we generally avoid doing a posterior interrupted with the knots inside. So it's posterior continuous, anterior interrupted.
Right. Next is how to prevent endothelial dissection of hepatic artery during anastomosis.
So this is obviously a major problem. One is both in the donor and even more frequently in the recipient, especially in the elderly recipients. So one is avoid holding the artery and avoid crushing the artery while you when you tie it. I mean, several people have several ways of how to avoid dissection. We generally lift it up with a loop and then just put clips and not tie it to avoid the circular shear. Other important thing is when you have some dissection is occurring, immediately put a bulldog just below it, because the blood dissects between these two planes and it keeps on dissecting. But despite all these things, dissection, especially in the because donors are usually young, fit donors. In the recipient side is a frequent problem. More important thing is to identify the dissection and make sure that you excise the dissected part, go proximally, and select a very healthy artery to do that. Many times, so I think people use they go till the GDA, where even if the dissection occurs extensively in the hepatic artery, you can use the GDA for inflow, or you might have to go more proximally. But identifying the dissection, and if you don't have a choice, you have to repair the dissection with fine stitches, get the clot out and repair with 8 stitches, and then do the anastomosis.
Can I just
we have to stop. Yeah,
we are already. Yeah. Thank you very much, Phani.
Thank you, Paari. Thank you, Phani. Thank you very much. So, TD, are you ready? I saw your screen in between.
Sir, yes, sir. I tried to. It seems
we could see your screen. Yeah.
Okay. So, share.
Yes, we are able to see. Just make it full screen slideshow. Yes.
So, good evening, and sorry for the technical hitch. It was very disturbing to me, at least. So, the recipient operation, as I have put a disclaimer. I have put a disclaimer that in PGI we are not doing live donor transplant, though sir has kept that it is live donor transplant. But as ordered by him that you can talk about this recipient operation, because it is almost so same, but there are some differences. So with that, I have taken a video about 4 or 5 slides, and then about video of 11.5 minutes about the technical tips of the recipient operation. So everybody who is doing a liver transplant, all of us know that it's a very challenging and a difficult operation. And we take this incision is bilateral subcostal with a midline extension. Most of the people use this incision only. And GP sternum is always excised. It gives very much good exposure to the suprahepatic IVC with a very nice table fixed retractor. So liver is mobilized, cutting the umbilicus ligament, falciform, umbilical, falciform, left and right triangular ligaments. They all are taken down. And then the main steps are when the dissection of the hepatoduodenal ligament. And most of the centers, they go and ligate the hepatic artery as high sometimes as possible, so that you are having all the branches preserved. It is more important in terms of the live donor transplant. Then after division and ligation of the hepatic artery, it decreases the blood loss during the dissection. And then bile duct, usually cystic duct is ligated so that you can nicely loop the bile duct, and bile duct is also divided. So once these both structures are divided, we are left with some fibropathy and vascular tissue, and with the portal vein, which is the most important and which has to be left there. Then dissection goes to the exposing the IVC. So usually a dissection starts lower down, and while exposing the IVC, it is usually the ligament between the hepatic caudate lobe and supraphrenic area. The renal hepatorenal ligament is divided. From there is one tries to expose the IVC. We might find a small duct of the caudate lobe. So the duct is divided, and from here IVC is followed. So exposure of the IVC is done lower down. Then from there the caudate lobe is being mobilized. And as we know, there are 5-6 vessels apart from some collectors which are draining the caudate lobe, and they are meticulously divided. And toward the IVC site, it is either transfixed or ligated. one can use clip toward the gallbladder side, toward the liver side. And then on the left side also same procedure is followed. So here on the right side also you can see the ligament, which is Makuchi ligament is there, and IVC is looped from the door down. Usually we don't loop IVC in a recipient hepatectomy. And on the right side there are some pictures where, from you it will be from the left side, where hepatic veins are from the caudate lobe is draining. So these are the main basic steps which are done. And after mobilization of the liver, we have to reach to the insertion of the three main hepatic veins, right, left, and middle hepatic vein. Left hepatic vein might have the common opening. And in a live donor transplant, obviously the right hepatic vein is preserved, and middle and left hepatic vein is divided and transfixed. And this is the final step. Then we have to go down and take the portal vein, which is already dissected, go above the bifurcation, and both right and left ducts are either ligated and divided. And a portal vein is usually clamped, a soft clamp is applied just in the supraduodenal area, and above it is at the bifurcation. So we try to leave a good stump. As there was somebody discussing about taking one graft of the portal vein division. So there are some modification in the technique that depends on the status of the liver and caudate lobe hypertrophy and massive collaterals. And if it is there and one is getting lots of difficulty in dissection and bleeding is too much, then there are venous bypass, which is probably very less commonly used, but still there are some centers use. And then somebody can go and do a temporary portocaval graft, which is described by the Japanese surgeons. And this graft decreases the bleeding and congestion also in the mesentery. So it makes the hepatic dissection very easy. So these are what are the main points. So this is what is I have to say about my slide. And then I'm going to share my video, which is the same thing which is has been replicated in the video. So this is the video taken from a 55-year male, which has we did a DDLT. So as I said, most of the procedures are same. So incision is as Mercedes-Benz bilateral subcostal, and go as high as possible, and excise the jiffy sternum, and control the hemostasis. This is basically about 11-12 minutes video. And then division of the falciform ligament. And falciform ligament is also excised properly. That gives little bit of more space for the dissection. And this dissection is started at the porta after the mobilization. And one could see this is the hepatic artery. And in this patient, right hepatic artery was taking origin right and left very lower down. So right hepatic artery is being looped and getting ligated, and then it will be divided. So same procedure, as I said, it will be followed. And then after this, so this section obviously is very bloody. So one has to be very patient and careful, and no injury is acceptable in a recipient. And any mishap which will be there, it directly hampers the outcome. Outcome will be directly decided on the table. So we have to be very, very careful. This one is a left hepatic artery. So as I said, this patient has a very long division was very early. In fact, we could not reach the division. It was coming from the celiac. So both right and left has been divided separately. So mostly the major difference in a right and left, disease donor and live donor transplant is this one. that this hepatic artery right will be divided much higher in a live donor transplant. But so we have come to the now superiorly and going to mobilize the suprahepatic area. So taking a coagulation artery and having patiently going, we should also be careful that in this area also there are small veins and there may be collateral also. So one has to take the energy source and do very carefully. And then coming back, as I was saying, this is the caudate lobe is seen, and this is the area where this maybe perinephric fat is seen. So this particular area is being divided and try to reach the anterior surface of the IVC from below. And then dissection is proceeded upward. So small vessels, as I said, every vessel has to be ligated. We cannot take a chance of doing energy sources until unless vessel is very, very small. So we are very fond of using bipolar cautery when required, and harmonic also we use, and try to divide all the vessels slowly. So patience is the key. So you could see this right side, the dissection has started from right side. And we have to see each and every bit of the tissue, whether there is a small tubular vessel which is coming, because it bleeds like anything. And we don't want any bleeding from the liver capsule also at this particular juncture. It can happen sometimes, but we have to avoid as much as possible. So in the supraphrenic area, there is a tough tissue in the adrenal gland, right adrenal gland, and that also sometimes are very close to the IVC. And all this tissue is very thick, fibrous, and vascular. So as I said, this is the most important parts of the dissection. And once this dissection is done, then most of the things are done, especially from the right side. So you could see the IVC. Step by step, we are exposing the IVC and going up. Each and every vessel is being ligated and clipped and based on the diameter. So this is, we thought this is a Makuchi ligament and which has been divided. And this is a hepatocaval ligament, which is vascular and thick tissue. And once it is divided, we are close to the right hepatic vein. So so IVC almost, you could see this is the final part of the right lobe, which is being seen, and small vessels are still there, and it is slowly it is being divided. In this patient, what we decided in the beginning, based on the CT, that we will go and take a common opening from middle and left hepatic vein, and right vein we thought we will sacrifice. So that was done. So little bit of more dissection. Usually this was very heavy patient, unusual for the many cirrhotic patient, because they have ascites, they have things, but they are usually thin. But this patient was obese, and that's why we could see lots of things are being done in the depth. So again, this is the slowly right hepatic vein is, we are trying to loop the right hepatic vein. So my colleague Dr. Harjit and I, we are doing this particular operation. This IVC is almost, you could see IVC is almost seen from here, and totally exposed. So it's very important to expose the IVC from below and go upward slowly. So any mishap also, you have you can apply clamp, you can do any modification if required. So now we have reached that suprahepatic part of the dissection, and we have tried to clamp the right hepatic vein. As I said in the beginning, it was decided that we will take middle and left hepatic vein. So we have applied a clamp and toward the IVC, and ligating toward the bile duct. Toward the liver. So this particular right hepatic vein is being transfixed, being sutured. And in all vascular surgery, we know that every time it is sutured above the clamp, unlike in any other area. And this what happened that there was a the slippage of the ligature toward the hepatic side, so it is being transfixed again. So he must have blood transfusion, and blood loss is also one of the very important predictor of the post-operative outcome. So we have to be very, very careful. Now we are going toward the left side, coming from the below and going, dissection is starting from the left. So this is the caudate lobe, which is lifted from the left, and the same procedure has to be repeated, and all the vessels which are on the left side has to be dissected. So this patient, because of the heavy caudate lobe, superiorly we could not reach the insertion middle hepatic vein. So we thought that about 2 to 3 centimeter of the liver will be mobilized from the IVC after division of the this. So this is right and left and right portal vein. So we are dividing at the bifurcation, and lower down where clamp is, soft clamp is applied in the portal vein. So this is the bifurcation division, and this particular small amount of liver is still not mobilized because of the very, very big caudate lobe. So we have taken the portal vein because suddenly we get a very good exposure. So toward the left side there was some tissue left. So it has been divided after taking. Normally we don't do this. Normally nobody does, because the more an hepatic phase and more more and more congestion can be occur, and more hemodynamic instability can happen. But this was a compulsion and we did it. So almost you could see very little tissue is left, and this particular after dividing this tissue will go and explant the liver. So this is so little bit of tissue which is the left. So it has been rotated toward the left now, and slowly and slowly, that is one small vein was there, and it is being ligated, and after this vein probably IVC will be free. So more and more you are free close to the hepatic vein insertion. It's a better while applying the clamp, that partial clamping in a piggyback technique will be better, and that gives a good good graft, good length of the IVC with hepatic veins for the implantation in the during the surgery. So as I was saying, this is the suprahepatic, this is very tissue left, this is the IVC suprahepatic. So after division of this small tissue, will be just explanting the liver. So almost so in any textbook, if you see the recipient hepatectomy is very mentioned in a less than 1 page, because it is something which is not to describe so many things. It has to be seen how difficult it is, and small vessels, how they make your life difficult when they open without clamping. So now it has been so nicely mobilized liver. It is in the hand of one of our colleague, and clamp is always applied from the left side, so that person is standing on the right of the surgeon, and veins are divided as close to the liver. Maybe part of the liver tissue is taken, that can be trimmed after explantation. So this is a common opening of the left and middle hepatic vein is being divided, right, as I said in the beginning, has been this thing. So this is what is the explant. This is the IVC, and we are creating one opening here, and this is the whole explant exercise. But all our colleague and friends who are sitting here who do transplant, they know that how difficult is this part of the operation. So this is the common opening being made, and we are trying to see that how much space is there on the right side. So a good hemostasis. So before going into implantation, it is very imperative that we should maintain the good hemostasis. And there are people who take, we also take lots of proline underrunning suture in this area, because usually this this energy sources don't work, and they can be cause of the post-operative bleeding. So this is all about the hemostasis. So I will be happy to take any question. Thank you.
Yeah. Jayanth, can you please moderate?
Thank you, sir, for that wonderful talk. Difficult hepatectomy in a difficult patient with lots of portal hypertension, but very well done. So a few questions. I know this is not pertaining to LDLT, but in a patient with a large caudate lobe where the explant is difficult, you are losing blood. Would you consider, resecting the IVC with the liver and doing a complete cable replacement?
So here we have not done. See, in this patient, 1 unit blood was given on the table. So, but we have not done complete cable resection. But it might be a compulsion. But I worked in Karolinska. I never saw them doing this. One more technique I saw that sometimes they will put a clamp lower down and upper, 2 clamps IVC, and lots of fluid is pushed. Then they take the seizure and just divide the caudate lobe and leaving behind the small vessels open. And the moment you take the liver out, then you take a suture meticulously about, there are 5-6 openings which can be taken care of. So I was discussing, we are also new in this area. We got very delayed chance to do, but we were discussing that once we get a very difficult liver, this thing, then we can use this technique, but not as a routine. So we are practicing that we should practice the same thing so that we are master in one, and we should know the options also. So this is one option I saw in with Kesitan and even in Karolinska. Sometimes it is done, and it's not very because both areas are clamped. So just you see the opening under magnification, and you go and take a 5-O-proline and just close the opening, and it takes about 20 minutes to close all the openings. But we have not done. I have just assisted this particular part.
Sure. So one more question. Any specific instances when you would consider doing a portocable shunt?
Portocable shunt is, I think it can be done when, as I said, it's a very high risk patient. You are struggling with the bleeding. Then I think it's a good option. I think better either shunt or this venous bypass. Both of them can be, but as I said, till date we have not been forced to do this, but we have all these options in the mind. So suppose we are forced to do, so we will be doing this. I think, yeah.
So in a patient with a portal cavernoma or a portal vein tumor thrombus, how will you plan the recipient hepatectomy? There's going to be significant portal hypertension.
So, Dr. Jayanth, as I said, this experience, we had a patient of portal vein thrombosis, but when we did the PET scan, so we found that there was a uptake in the thrombus. So we, at our stage, we deferred that operation because in DDLT, we are not, our team deferred that because it is very aggressive tumor and there is tumor is uptake. So if there is a tumor thrombus, so at this stage in our institute, we will defer it. But if there is a thrombus because of the cirrhosis phenomena and the thrombocytosis, then probably, I have seen people, you open the portal vein and take the thrombus out, and usually it's maybe a little bit more bleeding, but it's not that complicated. Sometimes you can push it, and the moment there is a flow after taking taking the thrombus out, then everything is maintained like this only. But hepatectomy will be definitely a little bit more difficult. So all these procedures can be done, but to be very honest, we have till date in PGI not done this particular part, that either shunt or this thing.
Sure. Thank you.
There is a comment from Dr. Yasir again, Pakistan. He says the same thing, that he has seen this with Dr. Kesitan and he's using it routinely in pediatrics. I think it would be good, Dr. Yasir, for you to communicate with our transplant surgeons who are faculty. Please email me. I will connect you to all of them because you seem to be very keen and interested in transplant. Jayanth, anything important you have to add? Otherwise, we can move to
No,
next.
sir, we're good. We can proceed.
Thank you, Jayanth. Thank you, TD. Thank you very much.
Thank
So
you,
now
sir.
we move on to the last session, which is on implant, and the speaker is Dr. Amit Rastogi, who is currently at Medanta, Gurugram, and Dr. Ajay Sharma, who's my colleague. He's the professor and head of the Department of Surgical Gastroenterology. He is the one who started liver transplant in Jaipur and Rajasthan. He will be chairing. Ajay, you are there? I think he has not been able to join. So maybe and TD, can I? No. Who will be? Any one of you, Jayanth or Phani or Pari, can probably chair. Amit, maybe you can start, and then I will ask one of the persons.
Good morning, good evening, sir.
Yeah.
Thank you for the invitation. I'm just trying to share my screen.
So everybody knows Dr. Amit, sir. He's a big surgeon in Medanta, and he is going to talk about the implant. Okay.
Dr.
Doesn't
Yadav,
need much introduction.
Yes,
Okay.
Amit, you are a co-host. You can share.
Yeah.
Okay, sir. I'm not getting the, when I say start screen, it take it to my screen.
Maybe stop sharing and then start sharing again.
It doesn't take me to, I'm not seeing my normal laptop screen that comes up. Just
And at the bottom there is a bar where it is a share screen.
Dr. Amit Rastogi co-host hai na?
So when I say share screen, it shows me other options. It doesn't show me my laptop.
I think I was having this problem.
Now I can see.
Yes.
Is it seen, sir?
Yes,
now we can see. Now we can see. Good. Yeah, please start.
Good evening, and thank you, sir, for the very excellent thing that you have started. This is first masterclass, and with the kind of response that we got, I think we should be doing it more frequently in all the subjects that you feel.
Sorry to interrupt, but before unless I forget in the end, because we are running late, Dr. Sadiq Sikora called me today in the morning, and he has volunteered to hold the next. I was planning some other subject, but he has volunteered to hold the next masterclass on safe cholecystectomy. And since that is a topic of great interest to general surgical audience, we will do that in the last week of July. So I will announce that, and then of course we'll do more. Thank you. Please carry on.
Okay, sir. So what I would be, as sir, you mentioned that this talk is primarily for the students. So I would not be giving into too much of technical details, and we would be basic about how implantation is done, and the various scenarios and the basic principles. And then if there are questions, we can go into details. Otherwise, we'll keep it to as if the people who are listening to it probably would have helped in implantation in some cases, or probably they might not have. So then they know basically what is implantation. So actually, I'm seeing half of my screen. Can I?
But we are able to see everything.
Sir, okay, sir. So, so liver implantation means that you have to, once a donor is done and you have removed the liver, like Dr. Yadav said, so you have an hepatic phase in the recipient, and you put in this liver into the patient is known as liver implantation. So there are two scenarios. Either it is a DDLT situation, which Dr. Yadav said, where the entire liver is removed and the entire liver is put in. And the other scenario is LDLT, where half of the liver or part of the liver is taken from the donor and put in. So when you implant the liver or you put that liver into the recipient's body is implantation. The liver implantation, if it is done for DDLT or for LDLT, you have to do three things. You have to establish outflow first, then you have to put in the inflow, and then finally you have to do the bile duct. So outflow means either if it is a DDLT, you have IVC with the liver, you would put in the KEVA, and then you have various ways of doing it. Or if it is a LDLT, then you do not have the cava remains in the donor, and then you put in the hepatic veins. Inflow is same. Inflow is either portal vein or hepatic artery. And once the vascular inflow is done, towards the end, the bile duct outflow needs to be reconstructed. So the bile duct. So DDLT or LDLT, these things needs to be implanted. Depending on the way how the cable or the hepatic vein is implanted, you can have two scenarios. You can do total clamping, meaning you clamp top and bottom cava, and then you have the entire segment of IVC where you can make openings and join either the IVC or the hepatic veins. And in some situations, you do not want to do the cable clamp. There is a reason why you don't want to do it. You can do side clamping, wherein you put a side clamp onto the cava, and then the blood continues to flow through the part which is patent, and then you can do the anastomosis. There are reasons to do it. Actually, side clamping keeps the hemodynamics better maintained, and then you don't want to totally clamp the cava, but that's beyond the scope. So DDLT or LDLT, and total clamping or side clamping. So what I would do is, I would give a basic overview of how you do a DDLT implantation. Once basic principle is done, there are some changes in LDLT, and towards the end, I would show 2 small videos of benching and a little 7-minute video of an implantation actually. And I would speak less so that you can see it for yourself. So as I said, DDLT implantation, basic outflow is caval anastomosis. So DDLT liver comes with the IVC liver and the IVC. So you have to do cava to cava anastomosis so that all the hepatic veins are drained into cava, and then cava to cava anastomosis is done. Once it is done, the next anastomosis is portal vein anastomosis, where you join the portal vein of the graft or the liver harvested to the recipient portal vein, and then you join the hepatic artery to the hepatic artery of the recipient, depending on what kind of arteries and how many number of arteries. And finally, you do the biliary anastomosis. Most of the situation, duct to duct anastomosis is preferred, either DDLT or LDLT. You do Roux-en-Y hepaticogenoscopy for certain reasons. Either there are diseases like that, or there is a problem and you want to do it that way. But biliary anastomosis, duct to duct, is preferred. So caval anastomosis, there are 2 ways of doing it. One is the conventional or the classical technique, which was done initially in 1960s when Thomas Starzl started the transplantation. You remove the entire liver with the cava, and then you bring in the new liver with the entire cava, and you join top and bottom end of the cava. So this is cava replacement or the classical technique. Most of the people will not do it because of various reasons. Sometimes there was a question also, when would you want to remove the cava? So if it is very difficult, and then you know it is DDLT and the liver will come with cava, and the caudate is hypertrophied and there are a lot of issues, then you can remove with the cava sometimes and then implant. But then most of the situation, you would want to remove the liver with the cava in the recipient, and then one of these 3 ways you can join the cava to cava. So if it is done replacing the cava, it is classical technique, conventional technique. If it is done with keeping the cava, then it is known as piggyback. Piggyback is when one thing rides over the other. So you have a recipient IVC intact, and then you have a donor IVC which is riding on the IVC. So this is known as piggyback. And there are 3 ways of doing it, which I would better show it on a diagram. So this is the classical technique. Classical technique, you put in a clamp, lower cava clamp above the renal veins, and top cava clamp suprahepatically, remove the entire segment, and then you bring in the new liver, and you have a segment of IVC. You join the top end to the top end and lower end to the lower end. The advantages are that it is faster. You don't have to dissect the caudate. The disadvantage is that you have a longer clamping time, and then once you have removed the liver, once you have removed the cava, then you have a segment of cava missing. So you have to be sure that the liver that you get in has same amount of cava, which can be anastomosed. Sometimes it becomes trickier. The cava in the donor might not be such a long cava, and then you can have problems. But then in some situations, this is useful and can be done. Piggyback technique, as I said, you keep the cava, and then once the cava is intact, you can anastomose the donor cava into the recipient cava, either joining the RHV and MHV opening, or you make a separate opening into IVC, and then, or you make a side opening. So end to side, you can put in the left figure, you can see that the openings are made join the right and the middle and left hepatic vein opening, it becomes a big opening and you implant in this orifice. Sometimes these things are not possible, then you make a separate opening into the IVC and you join it there. And this is how on the donor side, you make a corresponding incision and you do it. All the caval anastomosis, if it is LDLT or DDLT, is done with 4-0-proline and it is a continuous sutures. This is a piggyback technique. As I said, you keep the recipient cava intact, you take the liver with the complete cava, close the upper end, close the lower end, and then you make a separate opening so that by side to side fashion you can do it. The advantage is in this situation, whatever is the size of the recipient IVC or the donor IVC, you can make the opening the way you want at the place you want. So sometimes you have a recipient cava which is very thin and the donor cava is too thick, or the vice versa. You can have problems. So side to side, you can make the opening at a convenient place and can do it. Most of the people now probably would be doing, including us, they would be doing side clamping with cava to cava in most of the situations. Portal vein anastomosis is simple. If it is DDLT, you have two ends of the portal vein. You do anastomosis with generally 5-0-proline. You do a continuous, and towards the end, you leave a growth factor. So you start from one end, suture it to one end, and then go back to the other end. And then once you tie it, you leave a growth factor. How much is the growth factor? Technically, it's not a clearly answered question. Pediatric anastomosis say 1/3 of the circumference should be left as growth factors. For adults, what we do is we do the entire anastomosis, allow it to expand maximally, and then you leave a small bit of growth factor. But then a lot will depend on what is the portal size, what is the portal flow, and in some situation, if the portal flow is too high, you don't want to leave too much of growth factor and vice versa. But technically, join portal vein to portal vein with a 5-0-proline and leave a growth factor. Artery anastomosis, there are various ways of doing it. Most of us would do generally an interrupted artery as far as LDLT is concerned. For DDLT, most of the anastomosis can be interrupted, even it can be continuous. The idea is to do the same technique over and over again. So there is no one technique which is better than the other. What you are used to doing every time, you should do it. But most of the LDLT situation, it's better to do an interrupted anastomosis because the arteries are not so big to have a continuous anastomosis. But then if you are used to doing a continuous anastomosis, it is fine. But generally, stick to one, and we would do interrupted sutures in arterial anastomosis, and we would do from anterior and then rotate it 90 degrees and then again do the other side. Generally, sutures are 7-0. Sometimes DDLT can be 6-0 and LDLT can even use 8-0. If you have a very small arteries needing less than 8-0, then probably you might have to go for the microvascular reconstruction technique. Either you do it or the plastic surgeons would do it with 9-0 sutures. Duct to duct for DDLT is simple. You have a large opening, single CPD, and then you do a duct to duct anastomosis. You would do RU in certain situations if the disease is such. For example, you have PSC, or if your previous duct is not available, but preferred is duct to duct. For LDLT, the biliary reconstruction, as was told by Phani and other people, that it is the Achilles heel, and you have a lot of variations and various ways of doing it. You need to, so there are various which we can't discuss it here, but then there was a question asked, should you keep the knots inside? We would always keep the posterior knots inside. See, the thing is, it's a absorbable suture, and 90 days, the PDS that you would use, once it is an absorbable suture, which will actually lose all its strength by 90 days or maybe earlier, the chances of stone formation and these things are very less. And on the contrary, trying to keep that posterior knots outside with a small duct can be very tricky, and you might have more problems and injuries. So we would always take corner sutures, put sutures inside, tie the knot inside, and then the outside knots would be outside. So we have tried various techniques, but then keeping the knots outside is not a very good option. And we have been doing it for so many years. And I think the stone formation and these things probably don't happen that way. The LDLT implantation, before I go on for videos, there is only one difference. In DDLT anastomosis is caval anastomosis. In LDLT, because you can't take IVC from the donor, you would take the hepatic veins outflow. So there is no caval to caval anastomosis. All the hepatic veins needs to be anastomosed to the recipient IVC. If there are one or two large veins, you would directly implant. If there are multiple small veins, which I have 1 or 2 videos to show you that you can join them and you make such that you can anastomose them. So that part of surgery is known as benching. So benching or bench surgery is an essential part before the implantation. Once the donor is removed, you modify the graft for certain reasons, and then you anastomose them, prepare them for the anastomosis to the recipient. So that part is known as benching. In fact, that is more trickier than implantation. And the idea is so that you want to make things most simple for implantation, because implantation, you have a countdown time, meaning you have a warm ischemia and you don't want to do so many things while implantation. So whatever modifications you have to do, you do it on the bench, and then you implant it once everything is ready. Portal, biliary, and arterial anastomosis are same as DDLT. Only thing is the length and the diameter and other things are very, very small and different in LDLT. But DDLT, the other things remain the same. So LDLT, venous outflow, if you have a right lobe implantation, then you would do right hepatic vein, middle hepatic vein, and sometimes there are accessory hepatic veins. Earlier, for almost more than 10 years, we used to do right and middle hepatic vein separately. Last maybe year or 2 years, we have started joining middle and left hepatic vein. So it depends on the individual center. The reason we started doing middle hepatic vein is because we have started doing midline recipient surgery. So implantation, we thought we'll just do one anastomosis, but then it is an individual choice. You can join right vein separately into IVC, middle vein into IVC. You can join them together, and accessory veins, you have to join them separately. If it is a left lobe LDLT, then left and middle vein are together and you implant. And if it is a left lateral, only the left vein is there. The one point before I go on to videos is there is some difference between LDLT implantation. If you have a conventional incision means you give the Makuchi incision where you have a small midline incision and right subcostal. We have stopped giving, most of us have stopped giving the Mercedes-Benz incision almost maybe 10-15 years. Most of the people would have switched from Mercedes to a subcostal incision, and recently maybe 1.5 or nearing 2 years we have started doing a midline recipient incision. So there is some implantation modification that we have done, but I would not discuss them here. So these are small videos. I would speak less and you would see, and towards the larger video we would have the complete implantation before we end. So this is a complex benching, meaning how you prepare the right lobe in the graft before you go in for the implantation. So this is a video of complex benching, means there were multiple outflow veins. Most of the things would be self-explanatory on the video. So you have, this is anatomy where the MHV was taken at the plane. So we took subtotal MHV. I would not go, there were multiple inferior. So that is why all these have to be sorted out on bench before you go in for implantation. So there were 2 inferiors there. As you can see, this is not a routine scenario, but this is a benching purposely done to show you that if there are multiple veins, how do you do it? So this is the middle hepatic vein, which is subtotal. As you see, it's almost reaching the right hepatic vein. So there are various ways of doing it. Those days we used to use this PTFE graft, which has certain advantages. Now we have started using Dacron graft, which has some other advantages, the cost and convenience and certain others. So this is a PTFE graft that we were using for MHV extension. These are the 2 inferior veins that you've seen. You join them together. You try to make it as simple as possible for the implantation. So inferior hepatic vein joined. A lot will depend on the kind of modifications. The lot will depend on the kind of benching you need to do, and accordingly the modifications are done. So because there are 2 inferiors, so we have joined 2 inferiors into the PTFE, and then ultimately we will have 1 opening to make. So for implantation, you have 1 right vein, 1 middle vein, and 1 inferior. This is a little older video. We used to have this technique then. Sometimes you can do it now, but there is some other modifications that we have done. I will not be covering so many things, but just to give you an idea that if you have a complex benching, you do all this, make outflow as simple as possible for anastomosis, and then you have joined the 2 veins into this PTFE, and then You open it, and then you have only one opening to do. So this is known as boat graft. So now you see you have only one opening to anastomose for the inferiors, one opening for middle vein, and one opening for right vein. So this is known as boat graft. Another video on hepatic venous outflow reconstruction with a different scenario, just to show you. So there were multiple hepatic veins, and there are other things which I would not show, but so as you see, there is a right hepatic vein and there are two inferior veins, a segment 8 vein and superior hepatic vein near. You join them into one, and there is an inferior vein which you join them. As I said, the idea is to make things as simple for implantation. So ultimately, you just have to join one vein. Implantation should not take a lot of time because you have a time clock going, you have a warm ischemia, you have to take care of that. So like the other case, you have made the boat graft, you have joined the veins, and then these things, you can see the veins which are nicely open. So all these you join into this, and then you can anastomose. So you ultimately have 3 veins to join in this also. And this is the video of a complete implantation. This video would be 6-7 minutes. If there is no rush of time, I would like to present the entire thing. This is a pediatric implantation video, so the step remains the same, but then the video, the thing is that it's a pediatric, so maybe this will have the trick for both, so you can see. So it's a small child. What we are doing is we are holding the portal vein and we are dissecting the portal vein. The liver is removed. So now you have the fossa being prepared to implant. So this is how the portal vein is being freed. Children have a very small portal vein, and then you dissect, and then you reach to a point where you have a reasonable size of portal vein which you can anastomose. You can see the liver is removed on the top side and the cava is lying there. So you are preparing the, so you have removed the liver, your IVC is there, and you are preparing. So this is the opening of the left and middle hepatic vein, and this is a left graft because this is a child. So you join the left hepatic vein extending onto the MHV on the recipient side, and you join the LHV combined for the child. So this is a small child. In fact, it is a reduced left lateral segment. The idea is that the principle remains the same of implantation. You join the left hepatic vein. If it is a right hepatic vein, you join similarly on the right side. You anastomose the hepatic veins to the cava. In children, obviously, side clamping is generally not needed. One, it is not permissible because the cava is very small. So, and children tolerate the total clamping well. So you just clamp the cava, you make the opening of the size that is needed, and then anastomose. So this is the implantation of the left hepatic vein. We have done the posterior, and this is the anterior layer now. Once this is done, then we are joining the portal vein. So this is the portal vein in the graft, and this is the recipient portal vein. So you have to, there are 2 ways of doing it. You take anterior as markers, or you take corner. The idea is to keep the portal vein open. So we have taken the 2 sutures on the 2 sides, and then as you would see, you have a matching situation. So you have dissected portal vein accordingly. There are various tips or tricks or modifications that you need to do to get to this stage, but then that is not, we would not be discussing here. The idea is to show how the implantation is done. All the time you can see a white mop which is covering the liver. It's a mop with cold solution or ice cold mops, just to temporarily keep the temperature of the liver as low as possible, although technically it is warm ischemia. So you have done the portal vein. Portal vein is always done continuous. You start from one end, go to the other end, and then you come back and then keep it continuous. And then you have to leave the growth factor. The portal vein anastomosis is nearing completion. For children, the growth factor is mandatory and bigger. So this is one part of all implantation in LDLT, even in DDLT. This is known as flushing of liver. So because the preservative fluid is generally HTK or UW solution or IGL solution, all of these have high potassium and various other ingredients which are not good for circulation. If they escape to circulation, they would cause arrhythmias, they would cause various other problems. So you flush them off. So once it is done, the liver is implanted and perfused. You can see the pink liver, and then you see the arteries being done. So this is the recipient side artery. As I said, we would do interrupted sutures. So we would take corners, take both the corners, do one side first, all interrupted sutures, you anastomose, and then you turn 90 degree and then bring the other side on, and then you anastomose. So all our arteries, even for DDLT, we would do generally interrupted because you get used to one thing and always keep on doing. But then DDLT, you can have a situation where you can do a continuous artery. Some people would do continuous artery even in LDLT, but we would always do an interrupted artery. And the sutures that we do is this way. We would have a double needle and it will be inside out on both the sides. So inside out and then inside out, knots would be outside. So all the arteries, we would never take a suture from outside in for the fear that sometimes your intima can get lifted up and intima can have dissection. So always we would do inside out on all the arteries. And we will close all of them, then cut the anterior side. We'll keep the corners, rotate them 90 degree, do the other side, tie them, and then cut all of them. So that is how arterial anastomosis is done. And once we have done the anterior side, we cut the corner. This is how we rotate the artery 90 degree to the other side, so that the other side becomes anterior and it's seen well. And so the corners get switched, then you prepare the other side, and then you again take the sutures. The sutures, as I said, usually for LDLT would be a 7-0 proline. For DDLT, you can have 6-0 proline, and sometimes for LDLT, you need an 8-0 proline. And as I said, if there is a very difficult artery, sometimes if you have to take less than 8-0, it has to be a microvascular technique. Either you do it or the plastic surgeons do it. They would use a 9-0. Microscopic technique, we would ask the plastic surgeons to do it. We do not do it, although it can be done and many people do it. But then it's better done under microscope and they do it. But sometimes once in a month or once in 2 months, you might need their help. And this is how the arterial anastomosis is going. And then these are the thing, and then the Doppler is done. Once you confirm Doppler findings, hepatic veins and the hepatic artery, your implantation is done. And then you have the bile duct anastomosis, which is to be done. In this video, the child was very small, and for children less than 3 years, we would not do a duct-to-duct anastomosis. So a roux anastomosis was done. The technique here is the so-called modified Bloomgart-Skelly technique that we read in Bloomgart for hepaticogynosmy. You take anterior pre-place from left to right, then you take the posterior sutures from right to left, then you tie them left to right, and then, so we all know that technique. The same technique is followed, either you do roux or you do the bile duct anastomosis. You take anterior pre-place, then you do the posterior, you close the posterior. As I said, all the posterior sutures and knots would be inside for us. We would not try to put the knot outside, because I think there is more harm than good keeping the knots outside. You can have a lot of awkward situations, tear and all those things. So it's better to keep the knot, and then you have clear anastomosis. The technique remains the same for roux, either adult or children, or duct to duct, similar you will do it. And this is how the complete implantation is over. Before I end the talk, I would just show a side clamp technique, where this is an adult video, where side clamping means you don't clamp the complete cava. You just take a small, as you see, the cava is pated from below, and you have a small opening which is made, and then onto this opening you join it. The advantage is that the hemodynamic changes are less. All the blood continues to go. The kidneys doesn't get congested. So this is also known as the renal protocol, where you don't want to clamp the cava and congest the kidneys. So it helps in renal protocol. It is also known as cardiac protocol, because you don't want, once you clamp the cava, they have to give high inotropes, and once you release the cava, the BP. So you don't want these changes. So you would do side clamp. So side clamp is only for the hepatic veins. Everything will. This is the implanted it once the implantation is done to the side plan. And there are so many other things that we can discuss, but obviously we can't discuss all of these things here. So I would like to end here. Thank you.
Thank you, Amit. Thank you. I think there's one question in the chat from Dr. Yasir again from Pakistan. If you can take that. And there's another one from Niket Shah. Please take.
Thank you, sir.
So Dr. Yasir says, what is your opinion regarding triangulation technique for implantation of the left lateral sector graft?
Okay, sir. So rather than me reading, it would be good if we interacted through you. So actually, sir, the idea is to have a big outflow opening. So what I would advise the younger fellows is take a big opening on cava. Suppose you have a 4 centimeter vein, it's better to take a 5 centimeter opening on cava and trim the margins so that ultimately the opening becomes bigger. You would never repent making a bigger anastomosis. You would always repent or whenever you make a tight anastomosis, there can always be a problem. So the idea is to make the bigger anastomosis, a bigger opening on the IVC side. So this triangular technique is one of the ways of doing it. The other technique that we do is you make an opening and then you cut the margins of the cava on this side so that ultimately your opening is bigger. So triangular technique is one of them. The idea is to make a bigger opening. If you need triangulation, you can do that. But then if you make big enough anastomosis, triangulation technique technically means you take one side, you join the other side, then you make it like a triangle. So you have 3 places to knot. So it becomes a little trickier and the end results are almost similar. So make a bigger opening and just keep top and bottom and do it. We'll have the similar results. But then triangular technique is obviously a good technique. It's a classically described thing. But most of the time you can get away with taking the margins and big opening.
There's a question from Dr. Niket Shah that Dr. Estefan has described a retrograde flushing of the graft after the hepatic venous anastomosis and before the portal veins are anastomosed.
Actually, sir, as long as we understand what is the principle and what are we trying to do. So what are we trying to do is flushing the graft has 2 parts. You flush the graft with a solution and you let the blood out. So once you have clamped the cava for a long portal vein for a long time, you have the portal blood which is stagnant in the bowel, which will have a lot of lactates and other products of metabolites. So that you don't want to get into the circulation. So you flush that out. And you flush that out through the liver so that blood goes out and whatever is the product of which are remaining in the liver before reperfusion, they get out. The second part of flushing is when you put in a ringa-lactate solution and you flush out the preservative solution. So these things. So idea is to flush the liver out. You can do it prograde, you can do it retrograde. Generally, retrograde becomes it's a little awkward situation. It's easy to do it through the portal vein and bleed it out, but you can do it retrograde. Some people, they don't do it on the body. Once they've perfused, they've kept the liver ready, they perfuse it at the bench and then just implant the liver. So that can be done. In that situation, it can be prograde or antigrade. So there is nothing different in it. I mean, but most of us would always do a prograde flushing.
I think we are at 9:20, so I would not have more discussion. But before I close, I would once again like to thank all my former fellows who very readily and very happily agreed to contribute to this. And as I mentioned yesterday, 4 other fellows who are into transplant, they wanted to participate but could not because of time difference. K.R. Prasad and K.V. Ravindra, who are in US, and Sanjay Negi and Raghavendra Babu because of prior commitments. I would like if Anand Nagar is there to come on screen, Avinash if he is there to come on screen, and Hemanshi if they are there. So Anand is my colleague who's been handling Jaipur surgical tutorial for last more than 2 years. Avinash from Ahmedabad provides technical support for all our activities, and Hemanshi, yeah, Avinash is there. Oh, that is Anand, sorry. Anand.
Good evening, sir.
Yeah, so everybody, if you or your students want to join JST, please contact Dr. Anand. I have been repeatedly putting his number in the chat. So Anand is the one who's handling JST. And Avinash, are you there? Can you come in? Or Himanshi, if you are there, please come in. Himanshi is The young lady, yeah. Thank you, Himanshi. She's the one who's been providing technical support for all GST activities.
Thank you so much, sir.
Thank you. So I would like to thank the team, and with that we will close. And as I have put in the chat, the next masterclass most probably will be Dr. Sikora's Safe Cholecystectomy course. I think we will freeze the last Thursday, Friday of the month for these master classes, and I will be happy to have suggestions from all the attendees about what topics they want. So with that, I think with your permission, we will close this master class.
Thank you, sir.
Thank you, everyone. Thank you.
Thank you, sir.
Bye. We will close the session.